Good afternoon. I'll be speaking on phacoemulsification in myopic eyes. So, these are the most satisfied cataract surgical patients. All along their life, they were wearing those thick glasses, those messy contact lenses. Now you have done a good surgery. They are the happiest man because they can see of their own from the next day of the surgery. But for us, the surgeons, they are not the very decent patients because we have to do a lot of homework to tackle with them. So we'll have to think about the preoperative assessment. There are a lot of issues during the surgery we have to consider. Also, we have to take care of their postoperative period for pretty long time. So the first preoperative evaluation, the most important is the retinal examination. I suggest this can be best handed over to a VR surgeon or retinal surgeon because they know where are exactly the tears, where are the latiss, and about the posterior pole of the person. Because, as you know, the retinal detachment following cataract surgery in myope is quite high, up to the extent of 2.5%. This is in normal myope eyes where there is no latiss or other precursors. But if we miss all those things, flap, tear, then the number will naturally be double. So we have to be very careful. And again, look at this macula, all those maculopathy. We have to counsel these patients very well that look, you will be without glasses, but you won't be able to see as other patients are seeing. Then another problem is the IOL selection. We are all used to this normal IOL power from 17 to 26 diopter, but these high myopes, they have axial length always beyond 26 diopter. And our formulas, they are not good enough to take up these long eyes. So the best formula for us either is Haggis or the Holiday 2. But many of us do not have access to this. And Holiday 2 is basically very expensive. You have to buy the online thing. But for us who has an access to SRKT, it works decently. And as long as we do not have access to other good formulas, we can always rely on SRKT. And another factor is that many of the time they are presented with those posterior staphylomas. So sometimes a posterior staphloma sits right on the fovea. So in that case, mere A scan will not suffice. You have to take A scan from cornea to the lens, then B scan from lens to the retina, then add 2 and take the axial length as such. Sometimes we end up with a situation that the patient doesn't need IOL. Maybe he has 0 IOL power or maybe 0.5. Are we going to put an IOL in this situation? The consensus is that one should. Because these studies have shown that IOL has a vitreous stabilizing action. Especially in those situations when we do a YAG laser capsulotomy later because of PCO, this vitreous may herniate into the anterior chamber and may touch the posterior corneal surface and may ultimately lead to corneal decompensation. So whatever the number, one should put an IOL. Anesthesia is evident, high incidence of globe perforation both in peribulbar and retrobulbar. So the best anesthesia of choice is naturally the topical. So many will not be comfortable with the topical, then the next best choice is the subtenon. Because subtenon is easy and a 2.5 or 3 millimeter is suffice, and we always use a blunt cannula, so 100% sure that there will be no glove perforation. Then other intraoperative considerations like deep AC, you will have to look at the bottle height from time to time, less form, residual vitreous, more mobile nucleus because such a large eye, thin sclera, the chamber will fluctuate from time to time during surgery, and all these problems will end you in a PCR, and worse, the PCR, it happens, most of the time the nucleus drops down to the vitreous cavity. It's because the vitreous is liquefied, so it cannot support the nucleus. So all these things happen. But one thing I want to point out is that lens iris diaphragm retropulsion syndrome. This is one very common thing we encounter normally. What is this? What is LIDRS? When you put a irrigating phaco or IA tip inside the eye in a high myopic patient, there is sudden deepening of the anterior chamber. The iris lens diaphragm moves alarmingly posteriorly, as if they have sunk into the vitreous. And there is associated sudden dilatation of the pupil, and the patient complains of pain. So this is LIDRS. Just look at this thing. This is the eye with high myopia. Everything has gone down. Let's look at the second part. The person has did something, did a trick, and everything become normalized. Let me see in a live video. I am doing an IA, and see everything has gone down. Then again see what I am doing. I am doing a little trick. I'll tell you the trick later. Just see, I did a little trick with the iris repositor, and everything become stabilized. So this is LIDRS. It was first described by Zuberman in 1992, but in 2005, Robert Sioni actually found it. He put camera inside the eye to see why this phenomenon happened, and he renamed it as hyperdeep chamber. It mostly happens in high myope eyes, sometimes in post-vitrectomized eye. Why in high myope? You know, in myopes, most of the time they do not accommodate. So when we accommodate, our ciliary muscle is contracted. The zonules are relaxed and the lens changes. But in myopes who do not accommodate, they never contract the ciliary muscle. As a result, these zonules become stressed all the time. And this continuous stressing over the time makes them weaker. And when we go inside with the phaco probe, irrigating probe, they suddenly cannot withstand the pressure and everything goes down. So that was what Zuberman thought during that time. Abnormal zonular laxity in non-accommodators. But Robert Sioni put a camera inside to see what. And to his surprise, he found that the iris, during that phenomenon, the iris gets stuck to the anterior capsular surface, 360 degree. And that causes a reverse pupillary block. The fluid accumulates there, cannot go back. So then he came to know that this is the phenomenon. Iris get stuck to the anterior capsular surface. So he knows the response. So then Sioni described that it is a combination of two factors. One is the abnormal zonular laxity in the non-accommodators, and number two is the 360 degree iridocapsular contact. So before Sioni came into the scene, there was no respite to this problem. There was no satisfactory solution to this problem. But when Sioni known that this is the reason, the only thing is that you put a second instrument and lift up the iris of the anterior capsule. So this blockage, the reverse pupillary block is relieved and you have a normal anterior chamber. Just see this video. There are a lot of, first thing I went for the phaco, this happened. Everything went down. Then with the second instrument, there's a trick. I lifted the iris of the anterior capsule. The chamber become normalized. Then I went ahead with the phaco. So this is the phaco I am doing. I have completed the phaco. Then I'm going for IA. Just look. Again it happened. Everything went down. Again I am trying to lift the iris of the anterior capsule. So I tried to do an experiment. I went inside. Before that, I tried to lift the iris of the anterior capsule. First time I was not successful. Second time, I kept lifting the iris of the anterior capsule. Now I enter. Now you see the result. There is no LIDRS. So this is a very simple trick we encounter many a time during our surgery, And this is a very simple way to relieve this, and we become normal altogether. So in conclusion, this hyperactive chamber should be looked for any phacosurgery done on high myope or in someone who has not used accommodation for a prolonged period of time. Management is not difficult, as lifting of iris from the capsular adhesion reverts the block and achieves normalization of the AC, and patients should be counseled about the possible PCR and pain during surgery. Thank you very much.